Today at the National Press Club, dementia researcher Professor Henry Brodaty. About 433,000 Australians are currently living with dementia, and that figure is expected to double by the middle of this century. To discuss medical advances in treatment and prevention, here's Henry Brodaty with today's National Press Club address.
Hello and welcome to the National Press Club and today's Westpac address. My name is Corey McLeod. I'm a director of the National Press Club and the publisher of innovationoz.com, an independent publication that reports on policy and innovation. Our speaker today is Professor Henry Brodaty AO. Our theme is dementia. There is good news and there is bad news. The good news is that after almost 120 years, Dr. Alzheimer described the condition we are seeing some encouraging developments in research. The bad news is that there's 433,301 Australians living with dementia. The one is a member of my family. This is a figure that is expected to double over 800,000 by 2050. It is estimated to now cost the Australian economy $18 billion annually, approximately 0.65 of GDP, and this figure is projected to rise by $37 billion by the mid-century. Dementia is the leading cause of death for women and the second leading cause of death overall in Australia, and is a major cause and disability of disease burden. It is the leading cause of death in the United Kingdom. Dementia is people's greatest fear, especially those who have been personally touched by dementia, and that is most people in today's audiences. Professor Henry Brodaty will discuss these issues and possible strategies. Professor Brodaty co-directs the Centre for Healthy Brain Ageing at UNSW Sydney, which aims to achieve, through research, healthier brain ageing and better clinical care of age-related brain diseases. He is a clinician, researcher, policy advisor and former chairman of Alzheimer's Disease International, representing 120 Alzheimer associations. He is the past president of Alzheimer's Australia, now called Dementia Australia. We are indeed fortunate to have this eminent expert and scholar to address the club today. Join with me and welcome Professor Henry Brodaty to the podium.
Thank you so much, and thank you for the privilege of addressing the National Press Club. It's wonderful to see so many friends, colleagues and supporters here today. Special thanks to Ita Buttrose, who's really a remarkable living treasure and a tireless supporter for dementia research, and CHEBA, our Centre for Healthy Brain Ageing at UNSW Sydney. As Coralie said, dementia is prevalent. We're all frightened about it. We're scared. We make jokes about it. And being in Canberra reminded me of a joke that was doing the rounds a while ago, of a certain Prime Minister, whom I won't name, who, when campaigning for a forthcoming election, was visiting a nursing home. He was talking to all the residents, and he came across an older lady, and she was in a chair, and he sort of knelt down, made eye contact with her and says, "Do you know who I am?" And the older lady looked at him kindly and said, "No, but if you go to the desk, they will tell you." So we make jokes about it, but it's not a joking matter. Let me clear up some common misunderstandings. The definition of dementia is very simple. It's cognitive decline interfering with day-to-day function. It's that simple. But it's more than that, because there are over 100 causes of dementia. Alzheimer's is the most common cause. Dementia occurs in every country. While age is the major risk factor, it can occur at younger ages too. My youngest patient was 42. There are over 2,000 children affected by dementia, usually from genetic causes. So let me give you an example of one such person. In 1972, Jacob was a self-made, bright, active and sociable 52-year-old man running his own business. But something was changing. His wife was becoming increasingly concerned. He was becoming more forgetful. His partner was taking advantage of him financially. They saw their local doctor. They were reassured. He's just getting a bit older. But it got worse. He needed more help managing his affairs. He was becoming irritable. Eventually, they saw a neurologist who diagnosed Alzheimer's. Over the years, he required increasing assistance with self-care, such as dressing, toileting, and washing. And just as Jacob's family started looking at nursing homes, he died suddenly, aged 59, from a heart attack. This all too familiar story provides a touchstone for my talk today, which I've now retitled Dementia, Hope Beckons. And what I'd like to do is take you all on a journey from darkness to light. The darkness is Jacob's story. The darkness is the 433,001 people with dementia in Australia. The darkness is the 55 million people globally. The darkness is the $18.7 billion in direct and indirect costs, approaching 1% of Australia's GDP. The darkness is the despair, the fear that many of those affected endure, and the families' grief and distress. The darkness can be the agitation, the depression, the hallucinations, which can be dementia's companion. The darkness is the effect on all of us, our society generally. In 1972, and even now, the darkness was the lack of knowledge by medical practitioners. I was studying for my physician's exam then. Our Bible was Harrison's Internal Medicine, 800 pages. There was half a column on Alzheimer's disease, and that was it. It was said to be a rare condition occurring in people under the age of 65, a pre-senile dementia. Anybody over 65 had senile dementia, and nobody was interested in that. Services were pretty well non-existent. Post-diagnostic care had not yet been invented, and the concept of carers was rarely considered. Jacob's wife and family were on their own. They felt they had stepped into a void. Friends stopped visiting. Carer support did not exist. When Shakespeare depicted King Lear as mad, the word dementia was not in use. The word itself comes from the Greek demens, literally out of your mind. In 1972, dementia was officially a mental illness in the Mental Health Act. Through the 1800s up till the late 1980s, people with severe dementia were locked up in psychiatric institutions. I did my psychiatric training at Callan Park, and I remember that. What did the public know about dementia in 1972? Zilch. Maybe it's not so surprising, because in 1972, when there were about 12.8 million, 1 in 12 of us was over 65. In 2025, it's 1 in 6, or 4.3 million are now over 65. Senile dementia was seen as part of normal ageing. Second childishness, mere oblivion, sans teeth, sans eyes, sans taste, sans everything. So let's continue on this story from darkness to light. In the late 1960s and early 70s, neuropathologists started looking at the brains of people who died with dementia. And they found an amazing thing. They looked at people with pre-senile dementia and Alzheimer's, and people with senile dementia. And they were blind to the age of the patient who died. And there was no difference. Suddenly, dementia was not an inevitability, it was a disease. Dementia was a disease. In fact, it really wasn't a disease, it's a syndrome, because it's made up of over 100 different diseases that cause this picture. A lot of people have had dementia. Ronald Reagan had Alzheimer's. Margaret Thatcher, Winston Churchill had vascular dementia. Robin Williams, the comedian, the actor, suicided because of Lewy body dementia. We heard last year of Sean Connery and Gene Hackman dying with dementia. Gene Hackman in very tragic circumstances. Right now, Bruce Willis has frontotemporal dementia, which has robbed him of his speech. Dementia can affect anyone. I've treated politicians, some who've been in this spot right here, judges, doctors, and sportsmen with dementia. So where is the light? Well, research is our friend here, including major Australian contributions. In the 1980s, an Australian, Colin Masters, and a colleague, discovered the toxic amyloid protein. Now, please remember that, because I'm going to come to it again. It's considered to be the cause, or at least part of the cause, of Alzheimer's disease. Our other friends illuminating the path forward were the carers and professionals who were establishing self-help groups around the world to help people with dementia and their families. So in 1979, in the USA, Alzheimer's Association, in 1979, the Alzheimer's Society in the UK, and in 1982, we formed one of the first Alzheimer's associations in Australia. It was formed in New South Wales and Western Australia. And in 1984, we banded together to form what was then Alzheimer's Australia and now Dementia Australia. In that year, I went to the US and was part of a meeting with 4 countries which established Alzheimer's Disease International, now 105 countries. In 1989, we showed that a dementia carers training program could improve carers' psychological health, maintain people at home longer, and save thousands of dollars. The program was copied around the world. It was relaunched in the late 2010s, combined with respite care. It was so successful, it was calculated that if it was applied nationally, it would save $200 million in 12 months, or $5 billion over 5 years. The 2023 federal budget allocated $31 million to roll this out nationally. That's a 15-to-1 return on investment. That's why I keep stressing on research. In 1986, we had the first drug for Alzheimer's, tacrine. It showed promise, but it was a difficult drug. There were some dodgy things about the trial, but other trials showed benefits. The important thing was pharma became interested, very interested, because the population, the customer base was so large and growing. By 2000, we had 4 drugs for the treatment of Alzheimer's, but these were symptomatic drugs. They didn't attack the disease process. They were band-aids, not cures. Since then, there have been billions of dollars invested by farmers in trials, and up until 2 years ago, all had failed. I ran a drug trial centre for many years. Meanwhile, better diagnostic tools were coming. We'd gone past CT scans to MRI scans and PET scans, and then there was developed the amyloid PET scan. So that amyloid protein, the toxic one that builds up, we could now image that in the brain to make a more accurate diagnosis of Alzheimer's in particular. Population studies were revealing risk factors for, and importantly, protective factors against dementia. And in 1993, Australia launched the world's first National Dementia Action Plan. Now, despite all these advances, the numbers kept going up. Why? Because we were getting older. We're living longer. So let me fast forward to 2025. Have we come from the darkness to the light? Yes and no. In 2025, my friends ask me, Henry, what's the latest? Any breakthroughs? Why? Because they're scared. We see our friends, we see our family members developing dementia. Every time we struggle to find a name, we worry. When we misplace our keys or our glasses, or can't find our car in the car park. How many of you have wished away a senior moment? We all fear it. For older people, dementia is the most feared disease. So awareness has increased, and research has increased. On Saturday, coming, the Alzheimer's International Conference will open in Toronto. There'll be over 8,000 mainly young researchers devouring the latest developments. And there'll be clinicians, and there'll be people with dementia and family carers. In 1972, there was not a single journal devoted to dementia or Alzheimer's disease. My quick search now shows over 100 journals related to those issues. So that's the yes part. The no part is the numbers. The darkness is still there. Look at the metrics. The Australian Institute for Health and Welfare projects that by 2058, there'll be 850,000 people with dementia in Australia. The cost, we heard, $18 billion, double. Dementia, the second leading cause of death for women, the leading cause of death for women and second for men, and the second leading cause of disease burden. Nursing homes or aged care facilities, about 200,000 people. Over half officially have dementia. But I know it's a lot more than that. Many people haven't been given that diagnosis. The unsung heroes are the carers, the family members, over 140,000. And in one survey, over half of those carers spent 60 hours or more each week providing care. 60 hours. A very sad fact is that Indigenous people, our Aboriginal and Torres Strait Islanders, develop dementia at 2 to 5 times the rate of the rest of Australia. Now, we can do something about this. Better care before, during and after pregnancy and in early childhood, and particularly more education, could make a difference to this. The other darkness still persisting is workforce shortages. See, in 2021, for the first time, there were more people aged over 65 than children aged under 15. The population pyramid is changing. Now, with ageing comes dementia. It doubles every 5 years after the age of 65. So over a third of people aged over 90 have dementia. And as Australians are living longer, the oldest old are the fastest growing sector of our population, like centenarians. Now, there are 4 people of working age, 15 to 65, compared to every older person. By mid-century, it'll be 2.5 workers to every older person. And in some countries, like South Korea and Japan, it's already 2 to 1 and approaching 1 to 1. How are we going to manage that? So think about your children. If you've got children, say 25, in 40 years' time, there'll only be 2 people looking after every older person. And as we age, this greying of Australia will be magnified. So as the darkness continues, there are challenges. There's still stigma, even from people with dementia themselves and their families, and in the community, and sadly, by some in the profession. While most nursing homes provide excellent care, we still see examples of terrible, atrocious care, as exemplified by the Four Corners program, which led to the Royal Commission into Aged Care Quality and Safety. We still have gaps. So people with mild dementia are still waiting 2 or 3 years before they get a diagnosis. And there's really wide gaps in care after the diagnosis. Our survey showed that about 90%, about 2/3 of family carers said they felt abandoned. They felt they were in a void. They didn't know what was going to happen next. They didn't get a management plan. They didn't know what to expect. So there are still issues. Now, I mentioned titling my talk, Dementia Hope Beckons, because there is hope. We're now doing things about managing head safety. Footballers such as rugby's King Wally Lewis, AFL's Rex Hunt, have come out publicly and talked about chronic traumatic encephalopathy. And we now have rules to protect sportsmen, men and women, and our children from this. Australia funds a wide array of services: information, counselling, research and advocacy through Dementia Australia, helping with behavioural changes that can accompany dementia, such as agitation and aggression, through Dementia Support Australia, education of aged care workers, nurses, health professionals, doctors, including GPs, through Dementia Training Australia, and harvesting of data, because data is so important for planning. It's so important for research, and the Australian Institute for Health and Welfare is leading that. We have aged care packages to help people in the community, but sadly, there are reportedly 87,000 people still on the waiting list for those. Last December, the 2024 to 2034 National Dementia Action Plan was released. Unfortunately, with only $166 million in funding, too little for what Australia needs. Where are the navigators to guide patients and families after a diagnosis? Think about breast cancer. Navigators there have done a fantastic job. It's been brilliant. We can do this too in dementia. And it can be cost neutral. So we can do more, you bet. And it can save money. But let's start with what happens after a diagnosis. Remember the void that Jacob and his family were thrust into 50-odd years ago? It still exists. People have a stroke. What happens? They get rehab. People get a diagnosis of dementia, get your affairs in order. There's now a new paradigm, reablement. It's like rehabilitation. It means enabling people with dementia to be able to live positively for many years. I'm not being Pollyanna about this. I know in the later years that's difficult. But for many years, people can live well, maximise their abilities, and enjoy their life for longer. There are programs that exist, but they're sparse, and funding is lacking. In September, Alzheimer's Disease International will release their annual World Dementia Report. It'll be on reablement and rehabilitation. There's also hope in new drug treatments. After decades and billions invested, the first disease-modifying treatments in Alzheimer's were approved in 2023 and 2024. These are monoclonal antibodies. They're antibodies that attack the toxic amyloid protein in the brain and remove them. 2 months ago, the TGA approved donanemab. Another drug, lecanemab, is awaiting an appeal. These drugs slow the rate of decline, but do not cure Alzheimer's disease. They are complex drugs to administer. They require 2nd to 4th weekly intravenous infusion. They're expensive, costing $40,000 per year, and there are side effects, although ways to reduce these side effects are being found. The drugs only work in early Alzheimer's disease or people who've got Alzheimer's pathology in their brain, as we can see on, say, scans, amyloid scans, but don't yet have the symptoms, many of the symptoms. These drugs are a breakthrough, but they're complex to deliver and they're a challenge to fund. Better drugs are in development, but the drugs are here and we're not ready. Australia is not yet ready to deliver these. We need to prepare. It takes a lot of us to monitor it, repeated MRI scans and infusion centres. It's complicated. This leads to the next exciting development, blood tests. So Alzheimer's disease is important to diagnose accurately because these antibody drugs I mentioned won't work for other dementias. And we're not 100% accurate with clinical diagnosis. So our gold standard has been these amyloid PET scans and taking some spinal fluid with a lumbar tap, lumbar puncture or spinal tap, and analysing the proteins there. But these tests are intrusive and expensive. Within 1 or 2 years, we should have blood tests which can make a diagnosis accurately of Alzheimer's disease, and importantly, pre-Alzheimer's. Imagine if we could diagnose somebody having Alzheimer's pathology in their brain while the symptoms were still very mild, and then give a drug, or more likely, a combination of drugs to prevent that progressing. And it's not just Alzheimer's. There are spinal fluid tests for Lewy body dementia and Parkinson's dementia, and these being developed as blood tests as well. At our Centre for Healthy Brain Ageing, CHIBA, Professor Sachdev leads a National Health and Medical Research Council-funded Centre for Research Excellence in Vascular Dementia. Vascular dementia is really important. It's the second most common form of dementia. Professor Sachdev has spearheaded international diagnostic criteria for the diagnosis, and these have been accepted for publication in JAMA Neurology just this week. Cerebrovascular disease contributes to over half of the dementias. So even people with Alzheimer's have vascular disease as well. And in 20% of cases, it's the major cause. The last exciting development I want to talk about is prevention. We now know that half of the risk of dementia, generally, not just specifically Alzheimer's, can be accounted for by environmentally modifiable factors, things that we can do something about now. We all have the power to do more exercise, to keep our brains active, to educate our children, keep socially connected. We can monitor and treat high blood pressure, high cholesterol. We can compensate for hearing loss. We can try to avoid obesity. We can reduce the risk of diabetes and head injury. We can live in environments free of air pollution. We can not smoke and avoid excess alcohol. Friends, in Western societies, we have become really good at preventing heart disease. Rates of death from cardiac disease have steadily dropped in the last 50 years. It's now time for us to look after our brains. This year, Chiba published in Nature Medicine results of the world's largest randomised controlled trial, completely delivered online to improve cognition. It was called Maintain Your Brain, and it was funded by the NHMRC. Over 6,000 people aged 55 to 77 participated. And in year one, 3,000 got information and 3,000 got coaching. They got coaching on physical activity, they got exercises and feedback, on brain training, on nutrition, and depression, anxiety treatment and prevention. Both groups improved, but the group who got the coaching improved more, and it was highly significant. We then surveyed our participants afterwards, and over 2,000 responded, and they said they'd liked the program. They gave us some advice on how to do it better and how to reduce the burden on them, and we're now applying to get funding to do this nationally. We also did a cost-benefit analysis, and we showed that the cost of the program was offset by savings in health costs. So, ladies and gentlemen, we have a program that can delay the onset of dementia, possibly by a year or more. It's cost-effective. For every year we can delay the onset, we reduce the numbers of people by 10%. Remember, $3.7 billion in direct costs? Reduction by 10%, $370 million saved. Imagine what the return on investment would be if Australia did this. Improving fitness, not only would we improve cognition, we'd improve fitness, physical, mental and social health. I'm not going to talk about steak knives, but also we can increase productivity. How? By delaying dementia, because this would allow older people to have the potential to work longer. Our workforce, 19%, is already older. And if they have the potential to work longer, we'll increase our productivity. We designed this program a decade ago. We want to design it now to make it even more effective. We can institute measures to prevent or delay the onset of dementia. There is hope. It requires investment and will to achieve this. Australia has done this before. Australia has been a leader in prevention. Think about the slip, slop, slap for skin health. Think about Australia's leading the world in HIV. ITA was a leader in this field here. Think about A Life Be In It. Think about how we've decreased smoking. There is hope. Hope beckons. Hope for earlier diagnosis. Of course, diagnosis without treatment can be a burden, but treatments are coming. Hope there is much that we can do to improve the quality of life for people with dementia and to live positively for many years. Hope that services are improving. Inevitably, there are shortfalls. There's always more that we can do and should do. The issue is always money. But if we can show that services reduce demand, then services become sustainable. Research is our friend. Hope for prevention. We need the slip, slop, slap of brain health now. And hope for research. Funding for dementia has lagged behind cancer and heart disease, even though it contributes more to disease burden. Research is critical to find the best ways to provide services efficiently. So before I finish, ladies and gentlemen, I'd like to return to the story of Jacob. It was very sad to see an intelligent and vibrant 52-year-old man decline in the way he did. It was very sad to see the effects it had on my mother. Yes, Jacob's was my father. Jacob's gift to me was to lead me into this area. It motivated me to help establish and at times lead Dementia Australia in New South Wales, Australia and internationally. To be a clinician and to be a researcher and to conduct research into care, risk factors and prevention. Any of us could develop dementia. We should all care for dementia. Thank you for your attention. I'd like to thank my colleagues and our supporters from CHIBA, especially Ita Buttrose, Paminda Sachdev and Heidi Douglas, UNSW Sydney, Prince of Wales Hospital, Dementia Australia, NHMRC, the Australian Institute for Health and Welfare, Department of Health, Disability and Aged Care, the National Press Club for inviting me, and especially my wife Caroline for always being there to support me. Thank you all.
Thank you, Professor Brodaty. I'm going to start by asking, there's a window of time, you mentioned about 2 to 3 years before often there is a diagnosis. And I think that time is one that can be very confusing, not just for the person themselves, but for their families and loved ones. Given how powerful an earlier diagnosis can be, how is it that people can broach those discussions that can often be quite confronting?
It is confronting, and often people are fobbed off by saying it's old age or it's normal. And of course, we all do have senior moments. I saw people nodding when I was mentioning that earlier. But if it's progressive, if it's interfering with day-to-day function, if it's not just memory, it's language or difficulty following concepts or changes in personality, which can be more subtle, then really needing to assist with, so it needs to be two-pronged. It needs to come from the bottom up, so the people themselves need to seek help and their families, and from the top down, so doctors need to be aware of this and know there's much that we can do. And it used to be, we did a survey in 1994 of GPs. We surveyed 1 in 7 GPs in Australia, and most were nihilistic. They didn't feel they could do anything, they had nothing to offer, and they felt they lacked the skills. It's improved a lot since then. And we need to help GPs to know that. And I think with the one of the biggest things about the new drugs in 2000 is GPs felt they could do something. But there's so much more we can do besides drugs. There are programs to help carers and help people with dementia to live positively. So I think it requires the people themselves to seek help and us as health professionals to deliver it. Of course, many people are afraid. They don't want to get a diagnosis. I had an SMS this morning from a friend saying she's worried about her husband and he's in denial. He's taking herbal medicines and he doesn't want to see anybody. And so we can try and break down those defences, but the defences are a reason there because the anxiety underneath it is what really troubles that person. And to reassure them there is much that we can do, and there may be a reversible cause, not often, but it's possible. Yeah.
Okay. Just we're going to take some questions now. Melissa Code from the Mandarin.
Thank you for your talk, Melissa Code from the Mandarin. You mentioned that the funding for the national plan was insufficient. By what magnitude are we talking about needing more? How much more will actually result in meaningful change? And also, this is a public health issue which obviously spans several portfolios, aged care, healthcare, law enforcement, so many parts of the community. How do we get our systems to more intelligently respond to what will be a growing problem for our society?
Well, thanks for the easy question. That's all right. Okay. So I don't know about putting a number on how many millions. What needs to be done? And I sympathise with the government because there's always competing priorities and there's always other things that can be funded. But when it makes sense economically as well as personally to people, then why not do it? And so I mentioned the navigators, similar to what's happening in breast cancer. We proposed that to New South Wales government, and Anne Cumming, who's in the audience here, and I put a dementia services plan together to New South Wales government until they lost government, and so it landed on a shelf. But we'd had a pricing done by PricewaterhouseCoopers and showed that it was cost neutral. So there are things that we can do to do that. And it's a matter of working, it's a bit of a cliche, working smarter, not just more as well. And we should be able to do that. As far as being across different portfolios, well, healthcare, disability and aged care are now all under Mark Butler, so that takes care of that in a sense. But you're right, it does impact on education. I mentioned with Aboriginal people, education would be one of the major things that we could improve there to help with reducing the excess rate of dementia in those people. The importance of enhancing education, and also the other point you mentioned was in policing, I think. We know that people with dementia are very vulnerable to being scammed, to being financially abused, to being physically abused and sexually abused and psychologically abused. So these are all issues that do need to be addressed. We do this mainly through education, education of the police force. We did a program many years ago with bank tellers. If something looks odd, people coming in and starting to withdraw, and from a person who's suddenly become the best friend of the older person, to be suspicious about those things. So it's awareness, education, and arming professionals with the tools to deal with these things.
Thanks.
Thank you.
Can I just pick up on that? It's very interesting, that scenario about banks and vulnerability
Yes.
of people with dementia in the community. Are there other sectors where there's more training or an awareness called for that we can be more specific about?
Police. Police, people go wandering and get lost. I had a patient who wandered and was found 3 weeks later in the bushes. Of course, had passed away. And she'd wandered out of a nursing home when someone had left the door open for a fraction of a second, and out she'd gone. So people who are wandering, and also people who, as I was saying, abused in certain ways. Transport. Transport is really critical for older people, not just people with dementia, for all of us. But people with dementia are particularly vulnerable with that, and making sure that the transport is aged care friendly, and that the buses can lurch forward, and an older person is much more likely to fall and sustain an injury. So it does cut across a number of other disciplines.
Nick Stewart from Ability News.
Thank you very much for a largely terrific speech. And I say largely terrific because I was completely behind you when you said, we need to be careful about what we're eating, what we're drinking. But then you said, and increase our fitness. And I was rather less enthusiastic.
Okay.
I'd like you to explore, there was one area in particular that you were talking about. Obviously, there's a dynamic between reinforcing research and reinforcing actual treatment. Could you also look at the difference between researching different causes of dementia, treatments for dementia, and the way we go about dealing with dementia as a society?
They all work together, of course. Yes, and
do we need to put more money into researching the type of dementia, or rather than treatment, or what?
Yes, well, I don't think we can say one or the other. You really have to do everything. But one of the biggest gaps is implementation of research. So we have a lot of research findings, and we know that they make a difference. For example, we did a study looking at educating nurses in nursing homes about person-centred care. And we showed it had significant benefit, and we could reduce amount of agitation, and we costed it something like $8 a point on an agitation scale. It was a very small cost. And we then wrote to the Department of Health and suggested that we need to have this as a national program to do this, we didn't get very far. So we need the research, and then we need the will and the mechanism to implement these things. So.
And if I may, another issue, obviously people with dementia, there's the idea that routine can assist you.
Yes.
Do you believe that does that assist or does it mask?
No, that's a really good point. That people having a routine makes it a lot easier for the person with dementia to cope day to day. And if you take people out of a routine, so for example, going on an overseas trip can be quite stressful and very disorientating, plus the jet lag, of course. But having a routine does make a difference, and it's very helpful. And that's where the families working often with an occupational therapist may be able to develop a routine for the person and be able to assist them to live positively with dementia.
Maurice Riley, National Press Club.
I'm just asking these questions for some medical journalists, and I'm fitting in here because Simon Gross was meant to be in the spot, but he's at the dentist, so he's not having any fun either. So thank you so much for today's address. The first question comes from Marella Attard, who's at the Medical Republic, and she was talking about what role you think the Alzheimer's drugs will play in averting the crisis, and whether, and correct me if I've got this wrong, it's donanemab.
Donanemab, yes.
Thank you.
Yes, okay.
The drug recently approved by the Chief is likely to have an impact, and should it be made widely to Australians now?
Well, the latter will be evaluated by the PBAC, the Pharmaceutical Benefits Advisory Committee,
Yeah.
because as I said, it's $40,000.
Yeah.
If it's, the argument would be that if it's delaying progression of dementia at the early stages, then it may save those monies, and they're the drug companies, some of them are here today, will be able to argue that before the PBAC. I think these are a breakthrough. People are still declining on donanemab, about 27% or 30% less than the people on placebo. They're about 5 months ahead of where they'd be without the drug, or the people on placebo were. So there are benefits, but as I said, it's not a cure, but they're the first disease-modifying treatments. There are new treatments in the wings. It's likely there'll be combinations of treatments. These are the treatments aimed at the amyloid protein. There are other treatments that are being looked at the phospho-tau, or the tau protein, which also is involved in the development of Alzheimer's disease. But it's not going to be for everybody. It's going to be for a small number of people, as the current indications are. Because once people have advanced dementia, it's not going to help. And if people have vascular risk factors, like they've had a history of stroke or they're on anticoagulants or certain genotypes, then they're at risk of a hemorrhage, so they're not going to be suitable as well. So it's not the answer, it's part of the answer, yeah.
Okay, thank you, Corey. The second question is from Hearing Practitioner News, and it's been written in by Helen Carter. She's particularly interested in anything you might say about hearing loss and hearing aids in terms of potentially helping delay or prevent dementia.
A good question. It's a question about hearing loss. It was only in the 2020 Lancet Commission that we got news that hearing loss was actually a risk factor for dementia, and that's been confirmed since. And these were studies over 17 years, up to 17 years, showing that people with hearing loss had a higher rate of dementia subsequently than people without hearing loss. Since then, there have been studies looking at use of hearing aids and showing that they can ameliorate that risk by wearing hearing aids. Now, hearing aids, for many people, are difficult to wear. I remember my mother had a hearing aid. She died in her 90s. And the hearing aid lived very comfortably in the drawer for most of her life. And we could never get her to use it. And so it's important to start using it earlier, and particularly when you're younger and are more able to get used to it. Yeah.
Okay, thank you so much.
Professor, if I might, you spoke about the 70s and the real lack of awareness
Yes.
or understanding of dementia. But we spoke earlier, you had a moment in a radio interview in about 1981 that really was a bit of a light bulb moment for you. And can you talk us through it?
Yeah, thanks, Carly. So it was in about 1981 that I had the idea of starting up a self-help group for dementia, and I got together with a few other people, and we had various meetings, and we planned a public meeting at the Teachers Federation in Sussex Street, Sydney. And we tried to get publicity for it, and I rang up and spoke to 2GB, and the compere was John Tingle. I was hoping Laura Tingle might be here today, his daughter, but she's no longer the president of this club. He kindly interviewed me for that, and then I was able to get a lot of the people, I was working at Prince Henry Hospital at the time, to ring up and ask questions about this and say how important it was. And because there was such public demand, they rebroadcast this interview a few times, and we got 500 people along to the Teachers Federation, and from that we formed what was then called Alzheimer's Disease and Related Disorders Society, New South Wales. And from there on, we helped form Alzheimer's Australia and then Alzheimer's Disease International. So the media have been a friend to us over the years.
Very good. Okay. Seb Tan, AAP.
Hello, my name's Seb Tan. I'm from AAP. Thank you so much for speaking today. It was very informative. I just have a question about how you talked about the nationalisation of the National Risk Reduction Program that you would like to see the government implement. Yes. You also talked a little bit about athletes, particularly the ones in rugby and in contact sports, and how their concussions and things like that can contribute to dementia. I was just wondering, would this program be able to help alleviate other athletes of risks of cognitive injuries? And if so, how?
Well, there's certainly a lot of awareness about the head injuries and concussion being a risk factor for dementia. And it's very sad to see these famous football players that I've seen who are now hardly able to put two words together and having a lot of problems with depression and other neuropsychiatric issues as well. And so there are now increasingly policed rules about people having to come off the field and having gaps between playing. I don't know we have the evidence yet that that's going to make a difference. It seems logical that it will, and so we'll see that. But people want to play football. Look at the Lions test last Saturday and the cost of tickets to go to that. You know, people are wanting to see it and people wanting to play it, and they will. We just have to put as much safeguards around that as we can. Boxing, of course, is the one where we see it most starkly, and all of us will have seen Muhammad Ali in his later years and how that affected him. There was a first part to your question
so it's just about like the program. How would this how would a national risk program help?
Well, for athletes, they're doing the physical fitness thing anyway. They may not be eating as well as we'd like them to be, and a lot of times they do drink to excess as well. So they're things that they could avoid. But there are other things that are like the 12 risk factors, 14 risk factors now, accounting for 45% of the risk. That was the Lancet Commission in 2023 that came out showing that, yes. And so they're the things I mentioned during my talk.
If possible, I'd also like to ask a second question. We know dementia can also...
It's your third, I'm sorry.
Oh. So very keen, very keen. We know dementia can also cause elderly depression. What would be the impact of a program like a National Risk Reduction Program and more funding towards it have on lowering those health rates?
The link between depression and dementia is really interesting. It goes both ways. People who've had depression are more likely to develop dementia, and people who have dementia are more likely to develop depression. So it goes both ways. And I should emphasise, when I mention these risks, these are relative risks. So if the risk increases by 100%, like maybe doubling, that sounds terrible. But if the risk was 1 in a million, they went to 2 in a million, the absolute risk is minuscule. So people have to bear that in mind. Not everybody with hearing loss will get dementia. Not everyone with diabetes or with high cholesterol or with midlife obesity or with high blood pressure will get dementia. But they are at increased risk for those things. So that's important.
Thank you.
Thank you.
Adrian Francis from the ABC.
And I should say we're also collaborating with the Australian Sports Commission to write guidelines for athletes, particularly elite athletes, because it's not just about managing their head, it's managing their life after they retire from sport. They often go through great periods of depression, they often drink a lot more, they feel at a loss, they have deprived of the attention they got before. So there's a lot we can do to help them too. Thank you.
Professor, thank you so much for your wonderful address. It's really important to have you here in Canberra, so thank you. My name's Adie Francis, I work for ABC, but I'm also a carer in the community, and I'm thrilled to be here with my mum, who lives with early stage dementia. I just want to mention some of the interventions that we've been lucky enough to have here in Canberra on that journey, because that links to the question I'm going to ask you around enablement and also implementation of research. So here in Canberra, we're so lucky to have lots of different organisations doing great work with people living with dementia and also carers, like Dementia Australia's Living with Dementia program that we started on, and also some interventions through UC Hospital and the Centre for Ageing Research and Translation, the SPICE clinical trials for carers and people living with dementia. So we've now done 4 different short-term interventions here in Canberra as a dyad, a carer and someone living with dementia. It's been great, but then there's this sense of falling off the cliff when the funding stops. Our group's lucky enough to be starting to try and create something that doesn't exist in Canberra, in the community. So my question is really around enablement, because you touched on that in your speech. What's the gold standard for enablement of people living with dementia and the carers walking that journey? And how important is it to see the implementation of research like cognitive interventions, like cognitive stimulation therapy, and what role will that play in bringing down mortality and the load on carers?
Thank you very much for your question. We don't know that cognitive stimulation therapy, will reduce mortality, but it will certainly improve cognition, and there's evidence for that. So a lot of these interventions that you were talking about have got evidence behind them, but they're very sparse, as I mentioned in my talk, and they're not well funded, and they're 8-week programs, and then you do fall off the cliff. And the programs could continue, but then they can never take any new people in because there's no funding for it. So who should be responsible is the implication from your question. So what I was saying earlier, if we can show that continuing these programs or giving some stimulus for them financially could keep people at home longer, that would save money. If it will keep the families able to look after their person better and for longer, that would be cost efficient as well. So it's that combination of actually doing the programs, researching it, showing the cost effectiveness, and then presenting that argument. So should it all be government? Should it be government and people pay themselves, or some combination of those things? I think they're all good ideas. There are no cognitive stimulation therapy groups I know of running in Sydney, apart from one at Memorial Hospital. So it's really, we've got the evidence, we've got the research, but we don't have the people to be able to do it and to have it funded. So I think that could be something. The first question that was asked, what could be funded? I mentioned the navigators, but also it could be looking at the programs that, like you've just mentioned. Thank you.
Can you put a bit more flesh on the bone when you speak about the navigators? So who would be doing the navigating? Have you got an agency in mind, an existing agency?
I think they could be nurses or allied health professionals, that they would have a caseload of, let's say, 50, that they would be brought into action when a person gets diagnosed, and they'd be available intermittently in times of stress. They wouldn't need to be there the whole time. And that would continue until the point of admission to a nursing home. This is the model that we put together. And so you wouldn't be looking after 50 people continuously. You'd be having 50 people in the times of stress, at the time of diagnosis, the first time somebody has some behavioural issues or becomes incontinent. There are some of the issues that might come, or the carer becomes depressed or physically ill, unable to provide care. So providing advice and advocacy in those times could then help the person cope for better and for longer. So that's how I think it would work. Yeah.
Thanks.
And that person would then be in a community of navigators who would meet and have supervision, and then be linked to could be linked to local health network, local primary healthcare network. It could be linked to a local hospital. so those bureaucratic ways to link it are really important.
Tanya Bunchen, CEO of Dementia Australia.
Hi Henry. Thank you for the talk. Really appreciate it. Dementia Australia has been advocating, as you know, for this government to really focus on dementia. It will soon be the leading cause of death for all Australians. We know from Dementia Australia's statistics, and many of the researchers in the room will know this, that most Australians don't understand dementia. They don't understand brain health. Like you said, they get a diagnosis and they don't know that they can contact us or where to turn. So we've been advocating for 3 really clear things in this term of government. A commitment to fund a brain health campaign, your slip, slop, slap, but a commitment to fund a brain health campaign, navigation, and to upskill the workforce, because we hear too often from people who are living with dementia that they're getting care from people who aren't skilled. So my question to you is, now that you've got the floor, what's your advice to the 48th Parliament about getting this job done?
Well, I hope they're listening. Yeah. Well, some of the programs that were just talked about of post-diagnostic care are really important and would, I think, save money as well, at least be cost neutral. This is this is helping myself, but also helping with research, I think. But research not just into the core, back to an earlier question, not just into the cause and the drugs, but also into how to provide better care more ably. This is something we did do before with the Dementia Collaborative Research Centres in the past. The issues are also to do with, one of the things that was funded in the National Plan was about the interaction between hospitals and residential care and people coming out of hospitals. 1 in 4 people with dementia will go into a hospital in a year. I'm not sure what the figure is for older people in general, but it's a lot more with older people with dementia. And they're more likely to stay longer, have more complications, and have a higher mortality. So getting that right is really important as well.
It's a bit of political will.
Political will, and yes, political will.
Timothy Peach from Dementia Advocate.
Dementia Advocate for Dementia Australia. Thank you very much. Thank you, Professor Brodaty, for your wonderful speech. I am an advocate, but I'm also a carer for my wife who lives with dementia. But I'm interested in people who live with dementia but seem to be outside the general mould, if there is such a thing. People who have a diagnosis of dementia but who seem to function very well, and perhaps for long periods of time. So what are your thoughts on the role of neuroplasticity, setting down new neural pathways that seems to occur for some people living with dementia?
Neuroplasticity is really important, and it's something that even at any age, we can learn new things and we can lay down new pathways and make new nerve cells. Not as much as somebody who's 2 years old, but somebody who's 80 years old can still do that. There are some atypical cases of dementia which have very slow progression, and some of my colleagues are very sceptical about people with that, which is what I think you're alluding to. Yes. Yeah. And for example, frontotemporal dementia is usually a very quick disease, but the guru of frontotemporal dementia has described cases with very long progressions of dementia. Also, some of the newer dementias, such as, it's called LATE, which stands for limbic age association TDP43 encephalopathy. But LATE works well, LATE, yeah. And that may be a slower dementia, also hippocampal sclerosis. So there are other forms of dementia which can have slower progressions.
Yeah. Thank you very much.
Thank you.
Thank you.
Can I go back to something in your address? You remarked that there is a significant percentage of people in an aged care setting that haven't been diagnosed that are living with dementia. Is it important to make sure that those diagnoses happen in that aged care setting, if even for the provision of resources and making sure
yes.
the treatment's appropriate?
Yeah. Definitely. And it often is that everyone knows the person's cognitively impaired and they're in the home because they can't look after themselves. It just needs someone to make that diagnosis and put it on there. And then it may flow then to other services or other ways of being countered when people are doing the funding for residential care. I'm not an expert on that, so I'll take that with a grain of salt, yes.
Okay. Maurice Riley, NPC.
Research seems to be one of your strong themes in today's presentation, and research costs money. We're seeing universities go under a lot of strain at the moment for all sorts of funding, and usually the research is the easy one to cut in general terms. But I wonder whether you could make some commentary about how we collaborate internationally. This is not just a uniquely Australian or Western democracy problem. You know, what's the capacity for collaboration with all great minds around this small world?
It's a great question, and it's happening. It's happening big time, because now everyone is sharing data. All the funding bodies require us to make our data available to other researchers. We may have a moratorium of a year or two where we can mine it and write all the papers that are good for our CVs, but the important thing is to share data. And at Chiba, Professor Sachdev's led a consortium called COSMIC, which now has over, I think, 60 different studies from around the world, from 50-something countries, every continent. And any one of those people can share the data. We have a platform in Australia called Dementia Platform Australia, or DPAU, modelled on the UK platform. We can deposit our data there, and then there are various safeguards to maintain privacy and make sure people can't be identified. But this is, in the world now, data is so important, and sharing is now critical. I'll be talking at a conference, this conference I mentioned in Toronto, but I'll be doing it virtually. I'm not going there. But there'll be people from 4 different countries on the session that I'm talking at, and we'll be sharing information that we have about how to deliver prevention programs virtually online, like the one we did with Maintain Your Brain. So it's happening. It's happening a lot in the basic research, in the treatment, the drug trial people, of course, they're multinationals. It's happening in the care area of research as well. And it's happening in the epidemiological research, which is the one that we've been particularly involved in. So we have a study now called Memory and Ageing Study. We have about 800 people aged 70 to 90. We've been following up every 2 years to see what are the risk factors and protective factors. Comparing it to a similar study we did starting in 2005, and we want to see in 20 years, has there been a change, a generational change in risk factors and rates of dementia? And the evidence is from other countries that's probably is happening.
Thank you very much today, Professor Brodaty. Could you please join me in thanking